Welcome to Chapter 19 on the blood vessels of the body. In this first part of the lecture, Part 1, we are going to talk a lot about blood vessel structure and function, and we will talk a little bit about physiology of circulation. We will not be discussing the circulatory pathways in this PowerPoint presentation. Some of that was covered in lab. The rest we will cover in lab and lecture when we return. Alright, so I have my laser pointer working. This is a diagram of the systemic circulation. Last chapter we studied the difference between pulmonary and systemic. Right now this is all about systemic circulation. So do you like how the heart is a box here? The heart is pumping blood through arteries with oxygenated blood. It's going to a capillary bed here where the blood is turning purple and then blue. It's losing its oxygen, picking up carbon dioxide gas, and then flowing through veins of different sizes, getting larger and larger back to the heart. You should also notice this green section right in here. We're going to study this in the next chapter, but I'll point it out now. There are lymphatic capillaries that are closed-ended capillaries that start in tissues and go back towards the heart via lymph nodes and through larger and larger lymphatic vessels. They do empty into the venous system before the venous blood gets back to the right atrium of the heart. So it's good to know that there are two ways for fluid and cells to get back to the heart. The whole blood goes back through a series of veins, and then you also have white blood cells and fluids that come back to the heart through the lymphatic vessels. And that's all we'll say about the lymph for now. There are what are called arteriovenous anastomoses or AV anastomoses. Anastomosis with SIS at the end is singular. If I say anastomoses with an SES at the end, it's plural. And the anastomoses are kind of like a bypass around a town. They are in the outskirts of the tissue, and it's a way for arterial blood to go straight to the venous circulation. And that is useful sometimes if you activated your fight or flight response and you want blood going to certain areas of the body and skipping other areas of the body. Here, the AV anastomosis would help blood skip the area of the body that's right here. That sometimes happens with digestion and the fight or flight response. You don't want blood going to the digestive viscera when you're trying to run from danger, so you don't get much blood flow in the intestines here or the stomach, but the blood does stay in circulation and go back to the heart. You have large elastic arteries, such as the aorta and the large branches off the aorta. The arteries, as they get smaller and smaller and branch, they become more muscular. Arterioles are the smallest arteries. The arterioles have resistance ability. They are regulated by the sympathetic and parasympathetic nervous system, so this is a really important feature of these arterioles. You have terminal arterioles, which are the last ones before you get to a capillary bed. You also have metarterioles, which are smaller bypasses around capillary beds. And the metarteriole is regulated by these precapillary sphincters. That can allow blood to go through the capillary bed, or it can allow blood to bypass. Capillaries are the smallest vessels in the body. Red blood cells can only pass through the capillaries one at a time, so it's a very, very narrow capillary. Postcapillary venules are very small. They lead to small veins and then larger veins. It's important to understand that with the veins of the body, they have quite a capacity. They can carry a lot of the blood volume, and then it can be activated very quickly when the body needs more blood flow. Here's a picture of an artery and vein. We looked at these in lab, and we talked about the differences, how the arteries have strong muscular walls with lots of smooth muscle. They have a scalloped edge to the tunica intima and a large round lumen. Here it's kind of oval, but it's very much larger compared to this vein. The veins have less muscle in the wall. The tunica intima is not as scalloped, and the shape is often very irregular. Down here you have a smaller vessel You have adipose tissue around cushioning these arteries and veins. Excuse me. You also have the connective tissue tunica externa around the outside. There's a little bit of artifact here describing how this tissue has pulled away from where it was originally in vivo, or in the actual human. We went over the layers of the arteries and veins in lab. You have the tunica intima. There's lots of subdivisions here. The only thing I want you to know is the tunica intima has an endothelium that is simple squamous. And that is the only layer that remains with a capillary shown down here. So the capillary is in this area. This capillary network is in the tissue. It could be in muscle, it could be brain, in the liver, in your fingertips. Any tissue of the body that needs oxygen and needs nutrients and has waste to get rid of has a capillary network. So it's virtually everywhere. The capillaries have that simple squamous epithelium to allow gas exchange and nutrient exchange and waste exchange. The tunica media, we talked about how the muscle is always in the middle. That's smooth muscle and elastic fibers. Tunica externa is strong. It has lots of collagen fibers. And here on both of these vessels, this artery on the left, the vein on the right, you have vasa vasorum, and that is vessels of the vessel. So this wall of this vessel is so thick that it needs its own small blood supply, arteries bringing blood in, veins taking that blood away. In the lumen of arteries, there are no valves. In the lumen of veins, there are valves. We talked about how these are semilunar valves, similar to the semilunar valves of the heart. What were those valves? They were the aortic and pulmonary valves. There are three types of capillaries, so we're talking about capillaries where red blood cells can go through one at a time. You can see that here. Continuous capillaries are the least permeable and the most common. So these are often in muscle and skin and lungs and the central nervous system. They have tight junctions between the cells, making them less permeable. That's an important feature. Tight junctions cause them to be less permeable. The second type of capillary are the fenestrated capillaries. The fenestrated capillaries have pores. The fenestrations or pores are holes, basically, in the cells, and the holes increase permeability. So some vessels in the body, like in the kidneys or the small intestine, do need to have fenestrations to allow exchange of nutrients or to allow filtration. There are some tight junctions, but then you have the fenestrations that allow the filtration or the absorption to happen. So it'd be good to remember you have these in the kidney and the small intestine. And don't worry too much about the other detail written here on the left-hand side of the slide. The next type of capillary, the third type of the three, are the sinusoidal capillaries. And these are capillaries that are very, very permeable. They have a lot of spaces in them. They have a lot of holes, similar to the way that you have sinuses in your skull. There are big spaces. And the sinusoidal capillaries occur in the liver and the bone marrow and the spleen. And these are important for allowing cells to get in and out. So in the liver you have macrophages that can move in and out. The macrophages are looking for bacteria and other microbes that might have been ingested with your food and have gotten through the digestive system and into the bloodstream. So the liver is important for screening some of those things out. In the bone marrow, you have erythropoiesis and all types of hematopoiesis. You have blood cells leaving the bone marrow once they're mature, and so that's, what are those cells called? Those are called reticulocytes. They need to leave the bone marrow, so you need these big spaces so that the cells can leave the bone marrow and enter the circulation. Capillary beds are regulated by the sphincters, those precapillary sphincters. This picture is oriented in the opposite direction compared to a similar picture earlier in this presentation. Your textbook is playing a little trick on you. So make sure you realize that this is the arteriole with oxygenated blood on the left, and the vein with deoxygenated blood is on the right, or venule. This is a small vein. So the precapillary sphincters can tighten under sympathetic or parasympathetic control, depending on what's going on, to direct blood through a meta-arterial, which is sort of a throughway through the middle of a capillary bed. If the precapillary sphincters are relaxed, then blood can flow everywhere. So in this top example, the precapillary sphincters are open and blood is flowing everywhere through that capillary bed from left to right. In this bottom picture, the sphincters are closed, and so the blood goes through the meta-arterial in the middle of that capillary bed and goes straight to the venule. So at times during the sympathetic response, you don't want food being digested, you don't want to waste blood for digesting food and getting nutrients. You want that blood to go to the muscles instead so you can run or be active. So the precapillary sphincters are closing off and making the blood go through this meta-arterial directly into venous circulation. This next picture shows you how the systemic veins and venules have capacity for 60% of the blood in the body. And that's a huge way that the blood is stored. And if you think about having a job where you stand for a long period of time in a single day, and blood goes to your ankles, and your ankles might feel swollen, your fingertips might feel swollen, that's because the veins have a large capacity, and under those circumstances, more of your fluid than usual is pooling in those areas of the body. Don't worry about the percentages for these other things, but these are all areas where you do have blood volume in the body. But understand the important thing for this slide is to know that 60% of the blood is in the systemic veins and venules. This is a picture of an artery that's been almost completely excluded by arteriosclerosis and scar tissue. Imagine how much oxygenated blood is going to get through that little space compared to normal. So that's what happens when somebody has coronary artery disease and plaque forms. It's a combination of fibroblasts, scar tissue, lipids, and calcification at times. It's dangerous if that becomes a thrombus and moves. It becomes dislodged and moves and completely occludes a smaller vessel downstream. That's sort of what goes on with a myocardial infarction. I don't ask you about this on the test, but I think it's a really good picture to look at and understand. This is another example, cross-section through another artery that's almost completely occluded. Blood pressure varies in different areas of the systemic circulation. That's what's shown in this picture. Think of what an average blood pressure is. Many of you have taken blood pressures, or you've had your blood pressure taken. Almost everybody has. Blood pressure, an average one, is 120 over 80 millimeters of mercury. Even better would be 110 over 70 millimeters of mercury. So the blood pressure is fluctuating between these highs and lows in the large vessels. Blood pressure is measured in millimeters of mercury. If you don't understand what that means, I would encourage you to search for that information on the internet or read your book about what a millimeter of mercury means as far as pressure. The largest vessels are the aorta and the large arteries like the brachial and femoral arteries, so they would be in this area, and then you get down to smaller arterioles, capillaries, venules, veins, and the vena cava. So the pressure decreases almost back to zero when you're entering the right atrium of the heart, here on the far right of the slide. What's going on here is that when your heart pumps, when the ventricles pump, the pressure goes up to the high. When it relaxes and fills, the pressure goes down. And when you're measuring the brachial artery, you're in this range, and the pressures are almost the same as being in the aorta. You can't put a blood pressure cuff around the aorta, but you can easily put it around somebody's upper arm. So you're measuring the pressure in the brachial artery, and it's a close approximation to what's going on in the aorta. Now, if you look at the actual pressure, there is a little jog here, and that's related to the dicrotic notch. It's a little irregular right to left because of the filling that has to happen. Remember, the cardiac cycle has a filling phase, an emptying phase, and then a relaxation phase. And so the mean pressure isn't exactly in the middle between the top line here, the systolic pressure, and the bottom line, the diastolic pressure. You could think of diastolic as relaxation pressure. Systolic, you could think of the sort of high activated pressure, or pressure when some chamber of the heart is contracting. So the mean pressure is not the exact middle of that, and that's because of the differences in the heartbeat. So the mean pressure is a little bit less than you might expect. Once you get down into small capillaries, there's no difference between the pressures, the high and low pressures. This is only a phenomenon that you see in the large arteries and into the arterioles. By the time you get to the capillaries, venules, veins, and the vena cava, the pressure is all the same. There are no highs and lows. Pulses are measured around the body too. You can measure heart rate this way and also get a sense from using 2 fingers to measure a pulse about what the blood pressure is. It's not an accurate measurement, but you can still measure. You never use your thumb to measure the pulse. You use 2 fingers. So when we're in lab, we will measure some pulses, like on the radial pulse, on the thumb side of the wrist. You can try to feel a brachial artery, and that's what you're listening to with a stethoscope when you take a blood pressure. You can also feel your own carotid artery. I would encourage you to try this on yourself or on a friendly human being in your life. See if you can measure their radial artery or their carotid artery or one of these arteries in the foot, the posterior tibial on the ankle or the dorsalis pedis on the foot. Other pulses that can be measured or palpated are the femoral artery, the popliteal artery. For people who have surgeries on their limbs, sometimes it's really important to monitor those pulses and make sure you have good circulation. So for example, if you have knee surgery, it's important to measure these pulses, check these pulses regularly and look for color in the skin, and also check the temperature of the skin to make sure that you are getting good circulation to that limb. It's through a respiratory pump. And the respiratory pump happens when you take a deep breath in. When you take a breath in, the pressure is lowered inside the thorax and inside the lung tissue. It's lowered because the rib cage is moving out and the rib cage is also moving up. That lowers the pressure, and that also allows blood to flow back towards the heart. So the skeletal muscle pump and the breathing or respiratory pump are important for allowing venous blood to return to the heart. There are different factors affecting that mean arterial pressure that we showed on the graph a few slides back. One is cardiac output. You thought you were away, you had escaped cardiac output, but it's back. So if you increase the mean arterial pressure, the cardiac output has gone up, the stroke volume's gone up, and the heart rate has gone up. The other thing is the peripheral resistance. So the arteries, we talked about how arterioles can be regulated, the smooth muscle in the arterioles, the small arteries, it's regulated by the sympathetic nervous system. So if you have a decreased diameter of the blood vessels, or an increased blood viscosity or thickness, or if you have an increase in blood vessel length, you'll have more resistance, and that will increase the blood pressure. This is a really important graph or chart to understand, because all of these factors are things that can be modified to try to bring somebody's blood pressure down. Hypertension is a problem in our society. Many Western societies have this problem. If you have drugs that can bring the stroke volume down, can decrease the heart rate, can relax the blood vessels and increase the diameter. You could thin the blood a little bit with blood thinners like Coumadin or aspirin. All of these things can affect blood pressure, and so there are different classes of drugs, 5 different classes of drugs used to treat blood pressure, and many of them are affecting one or more of these factors at the top. So if you can learn these different factors and how stroke volume and heart rate affect cardiac output and blood pressure, that's great. It's also good to know how the diameter of the blood vessel, the viscosity, and the blood vessel length affects peripheral resistance and the mean arterial pressure. We'll talk more about this in lab. The last concept we're going to discuss in this PowerPoint is the regulation of blood pressure. You have this chart here. We've looked at this with glucose and calcium. We'll look at it with blood pressure. So I'm going to move to the next slide, which is just the top half of this figure. The top half of this figure, you do have a stimulus where you might have increased blood pressure for some reason. There are baroreceptors in the carotid sinus, in the neck, and in the aortic arch that are stimulated. They send a signal to the brain and tell that cardioinhibitory center from the brain to slow down. And that will decrease the sympathetic stimulation to the heart. You've got that stimulation going to the SA node, the AV node, and the ventricles. It's going to decrease the heart rate, the contractility, and therefore the cardiac output. So if those equations from the previous chapter are hard to remember, you might want to write that cardiac output equation on an index card and use that to study, because here it is being used to explain blood pressure. The other thing that the brain will do if the blood pressure is increased is to decrease the stimulation of the muscle of the arterioles, and it will cause vasodilation, which means the arterioles are getting larger in diameter, and that will decrease the resistance. It will be easier for blood to flow through a larger arteriole. So hopefully, with the combination of all these things these effects on the heart and on the vessels, will bring the blood pressure back down. In the next on this slide, and that will be all for this presentation.